What is up, everybody? The Longevity Game podcast is on the air. I'm just going to drink my pre-workout. Yeah. Today we're going to talk about a pretty potentially contentious topic. I think you guys are going to get a lot out of this one.
Bruh.
So let's go. Let's go. So, first of all, let me tell you who I am. My name is Michael Ward, and I'm the founder and CEO of Next Level TRT. We're a longevity and performance medicine practice in Texas. We see people all over Texas. And we've actually just begun seeing people in Nebraska. I'm also your host of the Longevity Game podcast. And today we're going to talk about estradiol hormone replacement therapy in women. And we're going to talk about estradiol in men because there seems to be a little bit of controversy regarding estradiol in men. So let's get to it. I think we should start with this title here called The Truth About Hormones. Hormone replacement therapy is riskier than they advertise. What is a woman to do? Oh my gosh. What's a woman to do? This was the Time magazine cover, July 22nd, 2002, after the Women's Health Initiative was published. Now, the Women's Health Initiative was a very controversial women's health study, which at the time was poised to be a 14-year-long study from 1991 to 2005. And the study was to determine a few things. The first thing is they wanted to discover whether or not, I think this is the primary endpoint, was whether or not estrogen therapy or hormone therapy caused cardiac disease and death. And the secondary endpoint was to see if estradiol therapy, estrogen therapy, was indicated or implicated in invasive breast cancer. And so that's what that was about. And as a matter of fact, the study was cut short. Instead of ending in 2005, it ended in 2002 because there was an overwhelming number of women who were actually experiencing invasive breast cancer as a result of hormone therapy. And so let's dig into that for a second, because the study was flawed. The study design was flawed. The information that they put out there as a result of the study was flawed, and it was just, the media loves salacious headlines. And so they took all hormones and they grouped them together and said, get off the hormones, And so, unfortunately, that's what happened. But let's talk about the study design. All right. So there was a lot of women in this study, lots and lots and lots of women. There was two cohorts. There was a cohort of women who had hysterectomies. Okay. So they did not have a uterus. And they were placed on Premarin. Premarin was an estrogen medication back during this time, and it's an equine estrogen, a synthetic estrogen. And then there were women who had not had a hysterectomy, and they were placed on something called Prem-Pro. And Prem-Pro was a medication that consisted of both the estrogen, the equine estrogen, and progestin, and a synthetic progestin. So the crazy thing about this is they kept calling it erroneously. They called it progesterone, and which is very far from the truth. Progestin and progesterone are not the same. And so progesterone, like micronized progesterone, which I prescribe for women, is a bioidentical progesterone, as closely related or resembles the progesterone produced in the body by the body. And then estradiol, 17-beta estradiol is the most abundant and most potent estrogen in your body. And whenever I put somebody on estradiol, that's what I use. I use a bioidentical estradiol. And so, unfortunately, the results of the study were published. The women who are in the Pro group had a higher risk of cardiac disease. They had a higher risk of strokes. They had a higher risk of osteoporosis. They had a higher risk of Alzheimer's disease, and they were experiencing invasive breast cancer. And so, the results were published, and it was just dispersed. The information was dispersed, and all hormones were grouped together. And women were advised, flush all your hormones down the toilet, don't use them anymore. And then providers or prescribers were advised to not prescribe anymore. And if you were on them, and if you were going to continue on your hormones, you better stop it at 60, right? Age 60. And so all this information out there was just taken and ran with and completely misinterpreted. They could have revisited the design. They could have said, well, why don't we use progesterone, natural progesterone, or micronized progesterone? And why don't we use a bioidentical estradiol as well? They didn't do that. And so since then, for the past two and a half decades, we've gleaned lots of great information, subsequent information from the Women's Health Initiative. But that initial bit about the hormones being bad, it resulted in, there was one large study that suggested or estimated that it was about 91,000 women from the ages of 50 to 59, not counting all the other age groups, but just specifically ages 50 to 59, who died needlessly as a result of following the information that was provided by the initial results of the Women's Health Initiative. And so what a shame that is. And so that's, but like I said, but we've learned lots of things since then. In estradiol therapy, women who go through menopause and then immediately get on estradiol or estradiol and progesterone, I'm talking bioidentical hormones, they have a decreased risk of Alzheimer's. They have a decreased risk of heart disease. They have a decreased risk of osteoporosis and early death, all-cause mortality. This has been proven over and over again since that Women's Health Initiative. However, I bet your primary care provider is probably not telling you that, because it takes usually, I think there was a study that said it takes usually 11 to 13 years from information to be discovered, transmitted, and then seeing changes in a medical practice. It just takes time, right, to get all that new information and to start seeing changes in treatments and therapies based on the results of those studies. So that being said, it's hard to know everything. It's hard to keep up with everything, and it's hard to stay on top of the research. So you'll still see providers who are saying no to hormone therapy because they worry about breast cancer risk, which there's not any. Whenever and this has been shown over and over again since then. Whenever using bioidentical hormones, even in women with the BRCA gene, right? I'm not, don't shoot the messenger. I'm just telling you what studies have shown, and I can list these studies in the description below if you want to read through those. But it's pretty wild. And so, yeah, I think that's important. I wanted to talk about that today. I think, I'm reading a book by Dr. Terry Dinouy, and she says that the biggest failure of the WHI reports was the classification of all hormone therapies and medications as the same with the same clinical outcomes. Yeah, I mean, that sucks. I get women in my practice all the time, and, we put them, whenever it calls for, whenever they are in menopause, we put them on estradiol and progesterone, and they come alive. They have just a huge benefit. They have better mood. They have more energy. They're able to lose weight. And that's just like signs. These are the things that they experience that they can actually tell me. But we also know that, like I said, they now have a decreased risk of all those things. That estradiol actually has been shown to reduce Alzheimer's risk and dementia risk. And one of the things about estradiol is it actually can easily cross the blood-brain barrier and can help prevent beta amyloid plaque, which is consistent with Alzheimer's disease. It prevents beta amyloid plaque formation. It also, in people who've had strokes, the body, there's a lot of aromatase activity that occurs, which is the conversion of testosterone to estrogen at the site of the stroke. And actually, you can see improvements in stroke symptoms whenever people have higher estradiol levels. And so, I mean, there's all kinds of things. In heart disease, it reduces lipid formation, or it lowers LDL, increases HDL, and thereby lowering cardiac risk. I mean, there's so much that estradiol and progesterone can do, but I'm just speaking about estradiol today. We'll go about progesterone another time. But super important, and so we should actually transition over to men, because at this time we need to talk about that, because I prescribe a lot of testosterone for men, and men who come from other clinics after not feeling good on the treatment that they're getting usually come over and they're on testosterone and they're on an AI, an aromatase inhibitor, which is usually an anastrozole. And aromatase is the enzyme that helps convert testosterone to estradiol in men and women, but only a little bit in women, not so much in women as it is in men. But yeah, so they come over and they're on an AI indefinitely. Some people will put somebody on testosterone and they will put them on an AI like an anastrozole indefinitely. And it's unbelievable, because if you crash a man's estrogen, it's going to cause all those other things that I talked about, right? So what do we talk about? We talked about increased risk of Alzheimer's disease, increased risk of osteoporosis, increased risk of Alzheimer's, heart disease, osteoporosis, fat accumulation, visceral body fat, metabolic syndrome, all these things. Well, men can experience all those things too if you crash their estrogen. And this is what likely will happen eventually if you put somebody on an aromatase inhibitor just indefinitely, because it's going to result in their body not converting testosterone to estrogen, and their estrogen is going to plummet until there's no more. And it's not easy to bring the estrogen back up, right? And it causes severe sexual dysfunction. You will not get an erection if you crash. The man will not get an erection if you crash his estrogen. And so it is not a good idea to take an estrogen blocker, or also known as an aromatase inhibitor, or an AI like an anastrozole or tamoxifen, also known as Nolvadex, or aromasin for an anastrozole, just because they have a higher estradiol level, right? Men benefit from higher estradiol levels, and as men's testosterone levels climb and they are optimized, the body's going to produce higher estradiol levels, and that's okay. There's a lot of benefit that comes along with that. There may come a time where it is so high that they may be having estrogenic side effects. And at that time, it may be a good idea to discuss possibly putting somebody on a aromatase inhibitor, but not just because they're on testosterone. That's a terrible idea. Bruh. I mean, it's not a good idea. It is not. But there are some patients that insist, dude, I just can't take when my estradiol gets this high, man, I can't handle it. Life gets rough, and so you just got to have discussions with those kind of people. But, there is a concern about, gynecomastia in men. And this doesn't happen to every man, right? This is something that happens in a very select few people who are genetically, they have a genetic tendency to develop gynecomastia if their estradiol levels are high. But that's not every guy. And so, again, this is, I don't like to cast a wide net and just generalize everybody or speak in absolutes. I don't believe in any of that. I think everybody deserves, that special treatment and that special care. So just putting everybody on an anastrozole too is the same thing. Casting a wide net, just throwing every testosterone patient on an anastrozole, it's a terrible idea. Anyway, that being said, I just wanted to make sure that we covered this because this is something that I get a lot of questions about, estradiol, especially in women, because they are still being told the same thing. You're going to get breast cancer if you take, if you get on estradiol. If you have estrogen sensitive breast cancer, you're going to, you shouldn't be on estradiol. This is nothing. This is farther from the truth, and women are having, increased risk of all-cause mortality, not being on hormones after menopause. And so anyway, all that being said, I am going to end it here, but I think it's really important for you guys to consider. I'm going to drop some links to some studies that kind of back up what I've said. And I would also highly recommend the book Hormone Havoc by Dr. Terry Dinawee. She is a doctoral level nurse practitioner who's been providing hormone therapy for years and years. And she and I have had several conversations at some conferences, and she's just a wealth of information. I would highly encourage you to buy her book. Check it out if you're interested in more of this information. And that is that. So I hope everybody has a great day, great weekend, and we will see you again on the next episode of the Longevity Podcast, the Longevity Game Podcast. I should mention, if you would like to be a guest on the Longevity Game Podcast, you can go to email us at be a guest at the Longevity Game Podcast. If you're interested in supporting or sponsoring the show, you can email sponsors at the Longevity Game Podcast.com. And also, if you have any questions or concerns, or if you have something to say, comments about a particular topic that we've discussed, go to hello@thelongevitygamepodcast.com. And I'll be reading your emails, and somebody will be back with you on that. All right, so everybody take care. Have a great day, a great weekend, and we'll see you on the other side. Take care, guys.